Hi, welcome to Health Talk with Nicole and Dr. Martha. I'm Nicole Tatro.
I'm Dr. Martha, and our guest today is Carolyn Weber of Northwestern Medical Center. She's here today to talk with us about BPPW. Oh, I was going to say W. BPV. I can't even say it.
That's a mouthful.
BPPV. I can't even say it. I might have vertigo. That might be the problem. So unlike Alfred Hitchcock in his movie, we're not talking about that kind of vertigo. We're talking about the kind that you can develop. And we're going to talk with Carolyn a little bit more about what it, how you develop that, how do you evaluate it, and then how do you treat it? Mm-hmm. So Carolyn, tell us a little bit about what your experience has been.
Well, what it is actually called is benign paroxysmal positional vertigo, and it is the most common type of vertigo there is out there. So vertigo itself is basically a sensation that things are spinning, that something inside your head is spinning or you feel very dizzy. And there are a lot of different reasons why you can have vertigo. The one we're talking about today is the benign proximal positional vertigo.
Which is caused by?
Well, it's basically mostly an insidious onset. There's no real cause to it most of the time, but it can be caused by trauma to the head. It could be caused by whiplash. Sometimes vertigo itself is basically what I'm talking about. It could be due to an acoustic neuroma or some inflammation in the nerve in the inner ear. Sometimes it's caused by migraines, but the BPPV is generally an insidious onset that happens. So no real known cause. And people can get it. The paroxysmal part is that it's a sudden onset. So people just suddenly have this kind of attack of dizziness and they don't know where it's coming from.
And from talking with people, it really can be very debilitating.
It can be very debilitating, yes. So some of the symptoms aside from the dizziness is that people oftentimes feel nauseous. They feel very foggy in their head, and a lot of times they have a loss of balance.
Almost like a seasickness.
Right. Yeah, it's very similar. It's, it has to do with your equilibrium, so seasickness is a really good analogy to it.
Which is why we actually named today's segment, When Your World Won't Stop Spinning. So Carolyn's going to help us learn what you can do so that your world can stop spinning. Because I was actually talking with a friend. Her mom suffers from vertigo for years and has for a long time. She was treated many years ago. She said about 40 years ago, and she's actually still maintaining and doing quite well with that just one treatment.
Right.
So it's amazing because there aren't many things that only take one treatment for you to feel, much better. She still has to do certain things. She said she can't necessarily sleep, on her left side. That's the side where the otoliths, which we're going to talk about. That's when the rocks in your head are not quite in the right place, right? So, Carolyn, tell us a little bit more about that. So the otoliths, they're in the ear canal.
Right. So we have a model here. And basically, everybody knows what the ear looks like from the outsides of our head, but inside it's a very complex part of our bodies. And there's the outer ear, the middle ear, and then the inner ear. And the inner ear portion is where this vertigo actually happens. So what we have are these circles called semicircular canals, and they contain a fluid in those ears, the endolymph. Part of where those canals can all come together is another part called the utricle, and in that utricle are where these crystals lie, or otoliths, and that's where they're supposed to be housed. But for some reason, sometimes they get dislodged from the utricle, and they end up in one of these canals.
So they go on a little bit of a roller coaster ride.
Go on a roller coaster ride, right. And so therefore you do as well. And so most typically they're in this one canal called your posterior canal, and but they also can be in the other ones. And so what happens is when those crystals get in that part of the canal, you feel very dizzy because your body is sensing that the flow of that endolymph is different. And it has a lot to do with gravity as well. So this type of vertigo is very symptomatic with changes in position. So maybe going from sitting to lying down, or rolling over in bed, or getting back up. And that's usually when people feel this wave of dizziness.
Right.
And it generally doesn't last very long each episode. a lot of people say, if I just stay still and close my eyes, it'll go away eventually. But it recurs, and like you said, it's very debilitating.
Yeah.
And people are scared because they don't know what it is.
Right.
And they're thinking, am I having a stroke, or do I have a brain tumor? You know, you don't know. And a lot of times it
That's
could
scary.
be just these crystals.
Yeah.
And it's treatable, which is the nice part.
Nice.
Do you find that it happens more in male, female, elderly, young
Yep.
people? Any particular?
Typically, it tends to be in the older population, so it tends to ramp up like after 40 and into the like 70s and 80s. People tend to get it. Typically, in women more than men, but no real known connection
Risk
with all of
factors
that.
or anything?
Okay.
Interesting.
You know, when you were describing the whole thing with the endolive and the, you know, the otoliths moving around, I was thinking of a whitewater rapid, you know, kind of ride. So inside your head, if you can kind of picture that, that's kind of what's going on. You've got those boulders and, you know, you have to try to move around these boulders, and that's what's happening inside your head. So no wonder it's so debilitating. One of the things that this particular person was telling me when I was asking her about her experience was her husband really did not understand how debilitating it was. He was like, what's wrong with you? Why can't you, you know, get up and, you know, come in and have breakfast with me? Or she'd say, I need to just lay here for a moment and get my bearings, and then I can move on.
Right.
So talk a little bit about how do you, because one of the things we, you know, mentioned earlier is that there are different types of vertigo. So
Right.
how do you tell when it's benign paroxysmal positional vertigo versus something that's caused by a tumor
Right.
or some other?
So generally, we get referrals from the patient's physicians, and it could be your general practitioner, it could be a neurologist, it could be a ears, nose, and throat specialist, and they do an extensive evaluation.
Okay.
It may include diagnostics depending on people's presentation.
Yep.
And typically when they rule it out and say this is benign positional vertigo, they'll refer to physical therapy. When we see patients in the clinic, we also do pretty extensive history taking, signs and symptoms, background of their medical, you know, history, and then we also do the evaluation that helps to confirm whether that's what the diagnosis is, as well as where it is. So it, you know, like I said, there's 3 canals. There's one canal, the posterior canal, which is typically where those otoliths end up being more rare. So probably 81 to 89% end up in the posterior canal.
Okay.
Much more rare, like 1 to 10% might be in the anterior or the lateral canals.
So they branch off to a different part of the river.
So, right, exactly, exactly.
Yeah.
So, so there are ways that we evaluate the patients to know which ear it's in, because you have the same thing going on the other side of your head, and which canal, and that determines how we're going to treat the patient.
Wonderful. So do you want to demonstrate for us? I think Nicole has volunteered.
Sure.
To kind of show us, run us through a little bit of the evaluation and what you do.
Sure. So, like I said, we would do an extensive history, how long your symptoms have been there, any traumatic incidents you may have had, any illnesses you may have had, anything that might be pieces of the puzzle to figure out why you're having this. After the history, we do more of a physical screen. So typically screen the cervical spine. We'll screen your balance. And then we also screen some of your eye movements and following, you know, being able to follow my finger, being able, you know, looking at the eyes, seeing if there's any unusual movement going on. And after that is complete, then we'll go to the actual testing for the benign positional vertigo. And that is what we can demonstrate here.
Very interesting. I actually had a couple of days of feeling dizzy.
Okay. Well, maybe we can help you out.
So on my back.
So what you're going to do is sit on the table, sitting upright with your legs out straight.
Okay. Well, better take my boots off, maybe. Didn't prepare.
So while Nicole's getting undressed for us, so Carolyn, tell us a little bit about how many patients you've treated with this.
You know, things come in waves all the time with any physical therapy diagnoses that we see. And so I would say, you know, probably in a year's time I may get anywhere from 6 to 8 patients. I mean, you know, I think part of it depends on the practitioners knowing they can send their
Yeah.
patients to physical therapy,
Yeah.
and who is trained in doing the evaluation and treatment of the vertigo
And maybe
as
this
well.
will raise some awareness to patients who know that they
Yes.
can actually
Right.
have some relief.
Well, a lot of people don't know
Just
that there
don't
is a
know.
treatment for this.
Exactly.
I was just going to
So,
say that.
Yeah, a lot of
That's our
physicians
goal, isn't it?
will.
With this.
Yeah, a lot of physicians will prescribe meclizine, which will calm down their symptoms. But if it has to do with these otoliths, it's not going to cure the problem.
Right.
It's just going to it's going to calm their symptoms down.
Band-Aid.
Yep. So I'm going to have you scoot back a little bit more. Okay. And that'll work. So for the testing part, after I've done my history, I've screened her. Sometimes you can get some feedback from patients knowing which ear it may be in based on how they get up out of bed or when they feel their symptoms. So say I've done all that and I'm suspecting it's your right posterior canal or your right ear anyway. The first test we do is kind of the gold standard of testing for this, and it's called a Dix-Hallpike maneuver. And so what I do is I'm going to support her, and I'm going to have you turn your head to the right, and then I'm going to have you lie down. And before I start, a lot of times I will definitely explain to the patients what I'm doing so that they're not scared, because they're already pretty anxious about all this. So telling them, I'm going to lay you down, your head's going to be back. Very important to keep your eyes open, because I'm also looking for spontaneous eye movements called nystagmus, and that's a pretty classic sign oftentimes. So just knowing that they're in good hands, they're not going to be hurt, we're just positioning them to actually elicit their symptoms.
Right.
So that's what we're looking for, is what is actually causing their symptoms. So with your head turned to the right, I'm going to have you lie back. And you're going to keep your eyes open. And I'm just watching her eyes.
And that's an important part, right? To keep the eyes open.
Important part is to keep the eyes open, because you're looking for that nystagmus. And sometimes people have it, sometimes they don't.
Right.
But it's definitely a classic sign. And if she immediately felt dizzy in this position and I saw the eye movement happening, I would know this is definitely a possibility.
So that would be a diagnosis in itself.
That would be
right
a diagnosis.
And then would you
Okay.
continue?
Yeah. So, and the other important part is waiting it out, because sometimes there's a delayed onset of the nystagmus or the symptoms.
Yeah.
So we wait it out generally, 30 seconds to a minute to see if those symptoms come on.
And then do you do the same, going in the opposite
So then
direction?
I would do the same. So I'll have you just go ahead and sit back up. Okay. And then I would do the same on the other side, see if that elicits any symptoms.
Now, it's important to return them to neutral so that the otoliths
Yes.
can get back into...
And just so she
Space.
feels like, okay, things are settled down and she's ready to move on, because people
Right.
do get nauseous with this sometimes. So you want to make sure they're staying comfortable, and that we're not just escalating all the symptoms one on top of the other.
Right.
What about ringing in the ears? complaints with
Tinnitus can sometimes happen, not typically with benign positional vertigo. Sometimes that could be more of a cause of maybe something else going on
Totally
in
right.
the inner ear.
I was just curious.
So is the treatment very similar to the evaluation?
Yep, so the treatment is quite similar. Where's our model?
Right here.
Show you. So Martha and I were talking a couple weeks ago, and as I was explaining what happens in the inner ear, she said, "Oh, just like that marble game."
Yes.
And it's it's a really good analogy, because these otoliths, say you have some in your posterior canal, they're going to be kind of stuck in here somewhere. What you're trying to do is get them back to that utricle.
Yeah.
Okay, so you have to position the head against gravity in certain ways to kind of guide those crystals to go back where they're supposed to be. So, so the treatment is very much like that. We're trying to get, with the head going back, we're trying to get first the canal position this way, then we're trying to turn it this way, then we're going back around until those crystals kind of find their way where they're supposed to be.
This reminds me of herding cats. I mean, very similar idea of trying to get things to go back where they belong.
So it's very dependent on the position and the angles, because when you look at this anatomy, it's complicated as it is, but it's also not on very straight planes. So you're at a 45-degree angle here. You have to get them in the right positions all the way through.
Right. Because we don't just stand in neutral all
Right.
day long.
Exactly. So I can demonstrate
Great.
what the treatment would be real quickly. So again, saying that she had symptoms that were coming from the right posterior canal, I would do a maneuver that's called an Epley maneuver. And that is basically doing exactly what I explained with that model. Okay, so I would tell my patient that we're going to do similar positions as we did with the testing, but now I'm going to go further. I'm going to have you first with your head turned to the right, then we're going to have it turned to the left, then I'll have you side lying, and then I'll have you sit up. And we're going to repeat this process several times because you're trying to work those otoliths back where they belong.
Okay.
Okay, so we'll just go through one round so you get an idea of what it is. So your head's turned to the right, you're going to go ahead and lie back. And typically, if she really has the vertigo here, she's going to be very symptomatic. So she might be dizzy. She might say, oh, I don't feel good. You might see the eye nystagmus going on. You're going to hold it for about 30 seconds or until those symptoms subside.
Okay.
Okay. And then the next position would be keeping her head extended and just going 45 degrees to the left. And here again, it might bring on symptoms.
Yep.
You're going to wait it out the 30 seconds or so. And then after the 30 seconds, I'm going to have you lie on your left side without lifting your head.
Ooh, it's almost done.
Yeah. And then we're going to hold in this position, do the same 30 seconds. And then I'm going to have you sit up so you can bring your legs off the table there. And as you sit up, just tuck your chin. And I'll often just kind of guard them a little bit to make sure they're feeling okay, and then they'll sit up and hold that tuck position for about 30 seconds.
So the reason that you lie them on their side, why do you do that?
It all has to do with the positioning of that canal.
Okay.
So it's just because it has to do with gravity, you're just gradually moving in the direction of that canal.
Okay. Now you didn't have them, you didn't have Nicole lie on her right side. Is there a reason you go only to the left, or do you normally do both?
No, if you've determined that it's in the right ear, this is the maneuver you want to use.
Oh, okay.
If it was in the left ear, we would be starting the other way and do exactly the opposite.
Oh, okay. I missed that part. That's great.
Yep. And that's the posterior canal. There's the other canals, and there are other positions for that and treatments, but in all honesty, I don't even know if I've used that once, because most of them are the posterior canal, and people will get up even halfway through the treatment. A lot of times they'll say, no, I don't feel anything, and I'll sit them up and they're okay.
Right.
I'll still do 2 more rounds of that treatment.
Yeah.
And each time they feel less and less symptoms.
Nice.
And then by the time we're done with the third, they're okay. You can lay them down. You know, I don't necessarily retest because you don't want to mess things up, but then we'll have instructions to go home with, like, try to stay upright for the rest of that day.
Yep.
Try to actually lie on your left side, because that's going to tend to be where the crystals won't come back out of that utricle.
Yep.
And just, you may feel a little not right for several days. You might feel a little foggy in your head, or like your balance isn't quite back, and sometimes it takes several days. But the immediate vertigo is generally cleared up.
Okay. Now, are there things at home that they can do to kind of maintain those otoliths being in, staying in that position that you want them in?
So there's a self-treatment that's almost identical to what I did. I basically guided her head.
Okay.
But at home, a lot of times I'll send people home with that similar exercise. The only difference is I don't recommend that people put their head off the end of a table and have it hanging there. So I'll have them use a towel or a pillow, and if they lay over that, they get just enough extension in their neck that they can get to the right position. And they basically go through that same sequence.
Okay.
And
Great.
I think for the most part, patients sometimes need to use that, but a lot of times if you've cleared it, it is clear.
Cool.
So do you see a big difference just after that first treatment?
Absolutely.
What do they report generally?
Well, again, some people still may not feel very well. They may be a little nauseous. They may feel kind of weak or a little bit out of balance. So sometimes it's hard to tell immediately. Where I see it immediately is just in treating them. From the first time I go through that maneuver to the third time, it's a major difference. There's no more nystagmus. There is no more initial onset of that vertigo happening.
Wow.
So, and then I'd follow up with patients a week later, generally by phone, just to say, hey, how's it going? And typically people say, I'm all set. I feel better. I don't need to come in. Occasionally people do need to come in for a second treatment.
Yep.
And usually that clears it.
Okay. That's fantastic. Wow.
good to
I can't believe that people live with this and not knowing, with just a couple of treatments, it can really change their world.
Yep.
So what would you recommend, you know, if we have people that are in the community and they say, oh, you know, a friend of mine has this, or what would you recommend for them? To see their primary care and ask for a referral?
Generally, yes.
Okay.
Yes. We, you know, in the state of Vermont, we can see people directly, but we still recommend that they see their doctor first, and especially with vertigo, because it can be something else going on.
Yeah.
It's nice for them to be cleared and
Just rule out everything
just to rule out
else.
everything, make sure nothing else is going on, and then if they're referred, you know, even though we go through that extensive evaluation as well, we know we can treat it.
That's fantastic. So now I know Nicole is also a physical therapist, and so with Bowen treatment, which we're going to talk about in our next segment, yay, is this something that you do as well, or is it something that you learned as a physical therapist and it's just kind of physical therapists like pick and choose, you know, what they treat?
I did learn this, but I didn't go that route, so I wouldn't feel comfortable doing this particular you know, treatment. Bowen work has shown good results with some vertigo, but I have actually referred people out, and now I'm really super happy that I have a face to a name that I can actually send them to.
Yes, and the name is Carolyn Weber. We're just saying. Now, Carolyn, I know you do some other things, some postural restoration and some things like that. Now, have you gone on to study more with vertigo? Is that how you kind of went that route?
I have taken 2 classes in it. You can get a certification in vestibular rehab, which would include the vertigo. And I am interested in that, so maybe it's on my list. Maybe someday I'll get to it.
I have those lists too.
Right. I'm currently working on the postural restoration. Once I get that, you know, under my belt a little bit more, then probably move on to the next one.
Wow, that's fantastic. And you're at the Georgia Clinic.
Yep, so I work for Northwestern Medical Center. We have a satellite clinic in Georgia, and that's mostly where I work. Yeah.
Wonderful. And I know there are other therapists, and lots of them in the area, but not everyone treats this.
Right.
So that's an important point, you know, to make, is you do need to go to your primary care, do need to be evaluated, rule out all of the other possibilities, make sure it is benign, and then send them to Carolyn. So we're just saying, or to someone, a physical therapist who, you know, does treat this. That's one of the most important things. You don't have to live with your world spinning. That's what we're trying to talk about today. The marble works, keep it for the kids. Let them play with it. Whitewater Rapids, keep that on the weekend. Enjoy it in another day. But for today, I think, you know, it's important that people understand they don't have to live with it.
That's right.
So thank you so much, Carolyn. We
Thank
appreciate
you.
you coming
Thank you so
and
much for
spending time
coming.
with us today.
No problem.
And
My pleasure.
All right.
We'll close
And
out our show.
Thank you guys for watching Health Talk with Nicole and Dr. Martha. Until next time. And please remember, we do Q&A. So if you guys have a burning health question, please hop on over to www.elitehealthandwellnessvt.com. Right over to the right, you can submit a question, and we'll do our best to answer your questions on air. You can leave your name, or you can be anonymous. It's totally up to you. Till next time, have a happy and healthy day.
Take care.